I'm going to turn right now to Dr. Sarah Newbery. I've got some slides from her, and all she needs to do is say next, and we'll get them up. But if we can put a spotlight on Sarah. Sarah, welcome to the Priorities Panel. It's great to have you join us.
Great. Thanks so much, Peter. It's really lovely to be able to join you, and really wonderful to see the richness of conversation before these presentations started. I also just want to acknowledge, Peter, what a delight it was to see a little one in your lap earlier on as I joined in. It reminds me how much we need to stay focused on building a healthcare system that will work for our children a generation from now. And I found that very grounding. So thank you for that. I am really pleased to be joining you as a rural generalist family physician in the community of Marathon in the traditional territory of the Ojibwe people of Big Tugon First Nation. Joining you today from my community and delighted to be able to participate in this conversation with you. The image on the screen is a view from our clinic window in Marathon. We look out across a short parking lot to our hospital, and this is a picture of the orange helicopter landing just a couple of weeks ago to pick up a patient. And I hope that you'll hold that in your mind as we have this conversation about the way in which care is really very integrated in our rural communities. I think I noted in the chat that Rajesh, you are in Thunder Bay, and so this will not be news for you, but for some of you who are perhaps less familiar with Northern Ontario, I thought I would take a moment and just orient you to the geography and remind all of us of the geography of Northern Ontario and our population context. So clearly this is a map of all of Ontario, and what I've chosen to do is place a red star on each of the 5 medical schools in Southern Ontario. So as you know, there's a medical school in London, Hamilton, Toronto, Kingston, and Ottawa in the east. And then there's the Northern Ontario School of Medicine in the north, and I've placed a blue star in Thunder Bay and one in Sudbury as the 2 campuses of the Northern Ontario School of Medicine University. So just to sort of bring that to life for you a little bit, we can drive for 6 or 7 hours and touch each of the 5 major medical schools in Southern Ontario, and it's a 10-hour drive between the 2 campuses of the Northern Ontario School of Medicine. And to drive from one end of Northern Ontario in Kenora in the west to the other end to Muskeming Shores in the east, that's 1,800 kilometers. You could put 4 of the United Kingdom in the geography of Northern Ontario, really, which begins at an invisible line at Parry Sound, but 4 of the UK can fit in this geography. If we did that, we'd have 240 million people living in Northern Ontario. In fact, we have less than 900,000, so less than the city of Ottawa is the population of Northern Ontario spread across this really vast geography, roughly 1 person per 1,000 square kilometers. We can go to the next slide. Next. Thanks, Peter. I want to just sort of put this another way in terms of our physician proportion for the population in Northern Ontario. So Northern Ontario, again, has 90% of the land mass of our province, only 6% of the population, and only 5% of the province's physicians. And this is important when we think about access. And that's Northern Ontario broadly, including our 5 urban centres of Thunder Bay, Sault Ste. Marie, Sudbury, North Bay, and Timmins. Rural communities tend to be disproportionately poorly served. And in the Canadian context, 18% of the population lives rurally, with only 8% of Canada's physicians working in rural places, and almost all of those physicians are family physicians. And we'll go to the next slide. I want to say with the next slide just a little mention about the importance of understanding the health of Indigenous people when we think about the Northern Ontario context. There are 133 Indigenous communities in Northern Ontario, 133 in Ontario, 88 of those are in Northern Ontario, and 30 of those are remote communities with fly-in access only. Their ability to access primary care is very limited. They have nursing stations, often a nurse or nurse practitioner, and family physicians who visit regularly but infrequently. And so there are some very specific primary care challenges for Indigenous populations in Northern Ontario specifically. Most of the communities of Northern Ontario that are Indigenous receive their primary care and much of their secondary care or hospital level care in rural communities as well. So here in Marathon, we serve the communities of Big Tagong and Netmezagimig and Wawa. They serve Mishippicotten. Sioux Lookout serves many of the remote fly-in communities. Kenora, another rural community, serves the Treaty 3 communities. So much of the primary care of our Indigenous population is delivered through rural settings, again, which are historically underserved communities. And we can go to the next slide. We've touched on the geography of Northern Ontario and a little bit about the population context. And now I want to shift gears and just encourage us to think about equity of health outcomes, which Dr. Pinto mentioned. And in Northern Ontario, we know broadly that there are significant struggles with achieving equitable health outcomes. At a very high level, the life expectancy in Northern Ontario is roughly 2 to 2.5 years lower than it is for the rest of the population. And I can imagine that for wealthy neighborhoods in Thunder Bay or Sudbury or North Bay, the life expectancy is probably the same as it is on average in the rest of the province. Much of that disproportionate loss of years of life is in our rural, remote and Indigenous communities in Northern Ontario. The OMA has attributed that to be because of a lack of access to healthcare service, and in part that's true, but in part it is because of challenges with the social determinants of health for the people of Northern Ontario. We have a disproportionate burden of mental health and addictions challenges in Northern Ontario. In fact, the 6 public health units with the highest rate of opioid-related deaths are 6 of the 7 health units in Northern Ontario. There is a huge struggle with addictions issues in Northern Ontario. And in fact, with many complex chronic diseases. And I'm sorry on your screen that map will be likely too small to see any of the detail of. But what that map is meant to depict is the rate of lower limb amputation. And what I want you to see is that in the little call out box, the 2 districts of Northern Ontario, Northeast and Northwest LIN districts primarily, are dark orange. That means they have the highest rate of lower limb amputation in the province. Lower limb amputation is typically a result of poorly controlled diabetes and cardiovascular disease. And so we have high rates of those complex chronic diseases that lead to serious complications for patients. And some of that is because of a burden of challenge with social determinants of health, and some of that is because of challenges of access to healthcare across the north. So huge issues of equity of outcome in Northern Ontario and huge challenges of geography. We'll go to the last slide. And what I want to do with the last slide is just depict for you a little bit of our rural northern context. And if we can just bring up that last image, what I want to show you is really these 3 sort of key areas in Marathon where we work. On the left is our senior supportive housing complex. There's 36 units there with many seniors who are living relatively independently, but with some supportive services. The picture on the top right is our hospital. We have 10 acute care beds. We have an obstetrical service, an emergency department, a chronic care wing with 12 beds, and we are building a long-term care wing in the near future. The bottom picture is our clinic setting. The top floor is our primary care clinic, where we have 8 physicians and our family health team with the social worker, nurse practitioner, physician assistant, and nursing staff. And on the bottom floor is our library and our COVID assessment center. And what I want to say with this is that there's a very fluid integration of primary care with the rest of the healthcare system in this local environment. Essentially, if you are in our postal code or the postal codes of the Indigenous communities we serve, you are our patient. We have a very highly geographically based service model. And we have functioned with a social accountability mandate to meet the needs of our population. We have 8 physicians. The 8 physicians work in our primary care setting. We also cover all of the emerge shifts, 24 hours a day, 365 days a year. We provide the long-term care and inpatient service and provide support to our seniors in this complex, and also to all of our citizens who need home service support. We have, through our team, a commitment to deliver as much care as we can as close to home as possible, because many of our citizens really can't travel for care. We now have an addictions medicine clinic that we run through our primary care setting. We use our clinic nurses to provide home and community care for our population that is struggling at home. We are the staff of the assessment center for COVID assessment, and we use our clinic EMR in all of the settings in which we work. We can access it from our emerge, from the COVID center, and from home when we're visiting patients at home. So we've built a very seamless system, and that's similar, I think, for many rural communities in Northern Ontario. And I think we have worked hard to be able to provide the care that people need as close to home as possible. And one of the features of primary care and health service here is that there are often times, as I mentioned, that people either can't or won't travel far away. Thunder Bay is 300 kilometers away. And so for people to travel for care or to ask their families to travel with them is quite onerous. As one example of care delivery, I'll share with you a patient that I've had in recent weeks who lives in supportive housing, was admitted through our emerge department on my shift. I followed her as an inpatient in hospital. When she was ready for discharge, discharged her back to my care, saw her in the senior supportive housing complex at home about a week or so later. And her goals of care now include simply doing what we can here, but never transferring her to Thunder Bay. And she recognizes that might mean that we move to palliation earlier than we might otherwise do. And our obligation as a group is to figure out as much of the care as we can locally to be able to support those goals of care. If I could choose 3 things to focus on, it certainly would be equitable distribution of resources, so that our resources in primary care are distributed in ways that will impact those who need to have that needle on health equity moved the most. And I think Dr. Pinto described that well. The second thing would be to use virtual care to support people to access care that they need while they stay as close to home as possible and while they stay connected to their primary care environment. And the third thing is, I think, that geographic model of care where funding is allocated to a geography to care for a population. We have lots of models of where that's working well in the province and how that can create the kind of accountability that one of you mentioned earlier. And I think if we could move to that kind of model, we could move the needle on the way in which care is delivered and the degree of accountability that we carry for that care. So I'll stop there and happy to take questions. I'll pass it back to you, Peter. Thank you for the opportunity to be here.